In case you're just joining us, this is the People's Breakfast, and I am with CT Muga. We're going to be having a conversation around cancer, and joining us for that particular conversation is none other than Dr. Zahra Mohamed Ahmed. She's a radiation oncologist, and also on the other side of the microphone, we do have Dr. Timothy Olweni, chairperson, National Cancer Institute. So, Daktari, karibuni tena sana.
Thank you.
Thank you.
Yes. So let's just start with you work as an oncologist. You're a radiation oncologist.
Yes.
Is there any difference from just a kawaida radiologist?
Oncologist.
Yeah.
Yes.
I mean, sorry, not kawaida oncologist, but you're a radiation oncologist.
Yes.
Then we have an oncologist.
Yes.
So you're specializing in the radiation part of oncology.
Yes. So we have two major aspects of oncology. We have the medical oncology and clinical oncology. So the medical oncology take care of the medical part of cancer, which is chemotherapy, immunotherapy, and all that. A clinical oncology does both medical and radiation oncologist. So if you have more interest in the radiation oncologist, you will do like maybe more training, see more cases, and deal more with radiation oncologists. But a clinical oncologist can do both medical and radiation oncology.
All right.
Yes.
Interesting. And you're with HCG, Health Care Global.
Yes, currently rotating at the Cancer Care Centre. Yes.
Karibu tena sana to Radio
Thank you
Generation.
so much.
All right, Dr. Olweni.
Yes.
Karibu tena sana.
Thank you.
This is Radio Generation. Maybe you can tell us a little bit about National Cancer Institute.
Okay.
Yeah.
National Cancer Institute is a state corporation that came into being by virtue of the passing of the Cancer Prevention and Control Act of 2012. It's a state corporation that was formed after appreciation of the rising burden of cancer and the need for more targeted and specific organization to deal with the cancer burden in Kenya.
All right.
It has got a very wide mandate, and the mandate is mainly to deal with leadership, oversight, coordination, also to arrange, organize collaborative efforts, anything to do with prevention, treatment, and control of cancer. We also give advisory to the Cabinet Secretary of Health on matters cancer. We're supposed to look out for patient welfare. Anything to do with their care, including access to healthcare services,
Right.
in line with the principles of universal health coverage and ethical principles in medical practice as well.
Yeah. I have a question around the funding of this specific terminal illnesses that we have in Kenya. This particular financial year, I don't know if you know how much money has been allocated to the fight of cancer, and just across board all cancers put together.
Well, we have funding. Funding, of course, it comes in different pockets, and the reason I say that is because you've got funding which is given to the National Cancer Institute, of course, to run its operations. You've got funding which goes through social health insurance in terms of paying for the healthcare. You've got funding, again, that goes to different other institutions in terms of infrastructure, whether it's in terms of personnel and so on, that is specific to taking care of cancer patients. So I can't necessarily give you a number.
Yeah.
But of course, there's funding that is allocated budgetary-wise. Again, healthcare is a devolved function. And that devolved function means, again, counties also significantly contribute in terms of taking care of patients with cancer.
The reason I'm asking this is because I sat here recently with individuals from clinical officers associations, and one thing they raised is the fact that the money that has been allocated to diseases such as cancer is not enough. Unfortunately, a lot of that money has been directed to outpatient services as opposed to where it actually does matter, and that is on issues to do with cancer, diabetes, and other illnesses, chronic illnesses.
While I do agree that the funding is never sufficient, I think we have to change our approach in terms of how we fund cancer and its management and cancer efforts. I do agree that we don't have enough resources allocated to curative treatment. However, there has to be a shift. We have to go more towards, I call it a leftward shift in terms of funding, in terms of priorities, because primary health care, we have to do screening and early detection, and that's the only way we'll be able to manage cancer, because at the moment we're diagnosing too many cases very late.
Okay.
That, first of all, has got very poor outcomes. It is more expensive. So at the end of the day, what we need to do is deploy further resources. So of course we are going to have a shift, and that's one of the reasons why, for example, the primary healthcare fund or the social health insurance initiative that we have under SHA was supposed to allocate significant resources to primary healthcare, and we integrate cancer care into primary care.
Yeah.
So that even as patients walk in, they're being reviewed by clinicians. They are being profiled in terms of what risks they have, and therefore being screened at an appropriate time. That's the only way we can be able to stem the rise in cancer and its impacts in our country.
Yeah. So
are you saying therefore that the problem isn't really funding, but it's the way we treat matters around cancer, how we think about what we ought to do, the priority that we seem to have towards the curative aspect of the disease as opposed to the preventative aspects of it?
Yes, I've always said that I believe that whatever you incentivize happens. And in our country at the moment, we have allocated too much resources, and when I say resources, I use that in the broader context of infrastructure, personnel,
funding,
training, funding, everything. We have allocated too much towards curative treatment, because that becomes the immediate problem. And to some extent, it's also understandable. When your house is on fire, right, you're going to do everything to put out the fire. You don't have time for long-term planning. But over time, it is important for us to know what caused that fire and how can we prevent that. And sometimes that is cheaper than putting out the fire itself.
Yeah. I'm going to ask you one more question before we move to Dr. Ahmed here. In terms of our personnel, the ones who specifically actually do handle cancer patients, do we have sufficient personnel, number one? And do we have facilities, our facilities rather, the ones that are available, are they well equipped to handle these particular cancer cases?
Our environment is resource constrained in all those areas, whether in terms of the infrastructure, physical infrastructure, whether it's the personnel, whether it's the level of training, whether it's the amount of money we are allocating.
Level of training?
Yes, even the level of training. And that is also, again, a change in mindset. And I'm saying, and that's why the National Cancer Institute at the moment is concentrating a lot in terms of integrating cancer and aspects to do with cancer in the curricula and having them there so that it is part and parcel, as opposed to these initiatives we have where people say occasionally it is World Cancer Day, let us go and screen, let us go and have a camp, let us go do this. It has to be part and parcel of the regular care that people get, just like it is for any other medical conditions.
All right.
Yes.
Okay, fair enough. Dr. Zahra, welcome once again.
Thank you.
If I can just ask you in terms, because he said in terms of personnel and in terms of in terms of even not the skills, but the training. What are your thoughts on what he has said, and perhaps you can let us know how HCG comes in to either bridge the gap or at least assist in that particular situation?
Okay, so as a country, in terms of personnel, we've come a long way, but still there's a huge gap. Like I was talking to one of the pioneers, oncologists in the country yesterday, and we had our first clinical oncologist in 1985. From then until now, currently we have more than 60 oncologists in the country. Yes, the numbers have improved, but still it's inadequate to tackle the cancer burden. And the second question was how
HCG comes in to assist, bridge the gap, or
yes,
how...
As a private facility, it offers comprehensive cancer care. Comprehensive, I mean from diagnosis, treatment, palliative care, all through to surveillance. And for treatment purposes, we see that currently in the country we have 20 to 22 radiotherapy machines. Radiotherapy is an integral part in cancer treatment.
Right.
And out of all these machines, we have Mombasa, Nakuru, Garissa, KNH, and KU as the only government facilities that have radiotherapy. Yes, we have increased the number of radiation facilities in the country, but still, that's not enough. And I think currently HCG is the only facility that offers a stereotactic type of radiotherapy. You see,
what? Sorry.
Stereotactic radiotherapy.
What is that?
Yes, radiotherapy is delivery of radiation to kill the cancer cells, and it kills the cancer cells by DNA damage. So modality of deliverance of this radiotherapy is different. So we have a spectrum from the 3D radiation to stereotactic, and in between we have VMAT and image guided radiation. So as more advanced the radiation technique is, the more precise the treatment, meaning that with stereotactic we can deliver high doses of radiation in a shortened period of time with less side effects. So like for example, for prostate cancer, with the 3D modality of radiation, we can take up to 7 to 8 weeks of treatment. But with stereotactic, we just treat it in 5 days. And the dose per day is high, the precision is extremely high, and the side effect profile is extremely low. So as an institute, it's able to offer that type of modality of treatment. And going back to speciality, if we do have enough specialists in the country, I feel like we need to reach a point whereby we have a lot of subspecialties. That's the only way we can really be very good at what we are doing. Like we need to divide this oncology into like a breast specialist, a GI specialist,
cervical,
yes, a gyne specialist, gyne oncology, and all that. So subspeciality is very important, and I think we should be heading towards that direction.
Siti, my mom is a cancer survivor. She was diagnosed with ampullary cancer, I think it was in 2020. Just at the height of COVID-19, and that particular time it was really difficult, to do movements, go to hospital and all that. Luckily we were here in Nairobi, and she managed to get her treatment at Nairobi Hospital. She used to do her PET scan at Aga Khan. She's actually still doing PET scan just to ensure that the cancer is gone. But we're very lucky, she's very lucky because it was diagnosed quite early, because it was at a point where she had jaundice because of the ampulla being infected and all that. So the reason I'm saying that we are very lucky, and the reason I brought it up, is because it was because of the jaundice that we noticed that she went to hospital, and it was captured quite early. But many other Kenyans are not. Actually, we are currently dealing with a case whereby a child lost his life because his cancer was caught quite late. So when we talk about diagnosis, and Daktari, this one is yours, what measures is the government doing, perhaps if you know of any, that they're trying to make sure that people are being diagnosed early enough, like in the case of my mother?
First and foremost, I want to say that it is important. Patients, first of all, have a role to play, but patients must be empowered to be able to be aware about possible signs and symptoms of cancer, but also in terms of the risks that are there, so that they are aware that they need to have screening, especially those who are already predisposed either genetically because of family history, heredity and so on, and those who, by virtue of age, for example, there are certain types of cancer where your risk is already high. So that is one of the things about awareness. And that's one of the reasons why when I'm called to a place like this, I come willingly, because we're going to help disseminate this information. That is number one. Secondly, again, the healthcare system needs to be prepared to meet these people when they come to seek help. Prepared in the sense that there's a healthcare worker who is aware and is going to do the right things when the patient comes for treatment. There's going to be enough tools. And when I talk about tools, I'm talking about whatever they need to do in terms of diagnostics, for screening and so on, and those things must be funded. So those are the basic things we have to do, because the moment we are able to screen people, catch them early, especially those where cancer has not spread, management is much easier. We've got those cases where what we call cancer in situ, where it has not even moved anywhere else. Their cure is actually possible. So those are the steps that we need to take to make sure that we stem this rise. The moment we delay all that and the system fails, and we have people presenting in a late stage, the system has failed the patients. We have failed the system.
Yeah.
The system has failed people, yes.
All right. And Dr. Zahra here has said that we need to have subspecialization.
Yes.
Yeah. How possible or impossible is that?
It's going to take a while. And my approach is always to say that let's work with what we have. Let's make the best of what we have. And that's why I'm saying it is important that even the resources we have, we optimize their use. Even oncologists that we have, let us make sure we use them maximally. We can leverage on technology, make sure that these expertise is spread out in a manner. For example, I'll give an example. If we can have a telemedicine facility, all right, where people can be able to, in a more remote location, then you can have people accessing an oncologist from my village in Ugenya, all right? Because the truth of the matter is...
But Daktari, we already have that. We have Zoom. We have WhatsApp video call. When you say televideo,
that's part of the infrastructure required. Yes, the communication component, but there has to be somebody on the ground somewhere who is seeing somebody and connecting to Dr. Zahra here, so that now we're having a conversation amongst professionals. You understand what I'm saying? That way we are now spreading her services to the periphery. One thing that she has not mentioned, which is extremely crucial, there's a huge disparity in the distribution of these oncologists. If I told you there are 70, I can outright tell you 80% of them are in Nairobi alone.
Yeah, because you said 60 actually.
Yes.
More than 60
Yes,
at the
okay.
moment, yes.
Yeah, so let's even go with that number of 70.
Yes.
Versus how many cancer patients that are currently known, forget the ones who have not been diagnosed.
At any time, I think you've got almost 100,000 people who are on treatment.
So we have 70
I mean, who have
doctors.
been diagnosed, who are living with cancer, isn't it?
Yeah.
So we have about 70 patients.
Yes.
70 doctors,
Oncologists.
oncologists, having to deal with over 100,000 patients.
Yes.
Let me ask this question.
Yes, doctor.
Who is an oncologist?
An oncologist is a doctor that specialized in cancer treatment. Yes, in cancer care in full, from diagnosis to treatment all the way through to surveillance and follow-up. That's an oncologist.
That's
yes.
an oncologist.
Yes. So you have to do your undergraduate first, go through 6 years of undergraduate, and then do your master's, whether 4, 5 years, depending on
Where you study.
where you study. Yes.
Now, I have 3 questions.
Yes.
One, I'm going to Dr. Luen. The institute that whose board you chair, of the functions that you have, what component does research have in that entirety of its mandate?
Well,
Research.
that's an excellent question. In terms of research, one of the things that the National Cancer Institute is meant to do is to be able to promote research, and research that is specific to our context. Because a lot of the time we rely on data that is international data, and you cannot just copy and paste a lot of these things.
Daktari, ngoja tu kidogo. We rely on international data that has been
Yes.
extracted in Kenya.
Not extracted in Kenya. I'm saying from other jurisdictions. For example, when we are managing our patients, it's going to be that this has been found to work, this has been found,
Oh,
these
so-
treatments and so on, this is the incidence and so on.
All right, carry on.
For example, global figures. But we need something which is specific to our context. And even beyond that, we need something that is, there's also regional differences within our country in terms of distribution and the burden of cancer. So the research that we fund, and we fund a lot of research through research institutions, universities, and through KEMRI, for example. So we fund a lot of that research. And even yesterday during our National Cancer Summit, we had presentations from 15 of the current studies that are going on in terms of cancer research in Kenya. We had a very interesting one on esophageal cancer, for example, in northeastern Kenya, in Wajir, which there were very good insights, which it's not concluded, but that is one of the roles that we play. We get a lot of funding from external sources because we don't have sufficient funds on our own. So one of our roles is to mobilize resources, and then we have those resources, give it to institutions that have got the capacity to be able to do that research locally. So that's how we build our local knowledge.
And when we talk about research, what stage of research do we conduct here? I mean, research is broad.
Yes.
Okay? Even simply observing, you're collecting data. Okay, so are they observational studies? What sort of studies do you conduct to inform you so that when you talk about the findings we have in Kenya with regards to cancer, we know specifically that this is what we're doing?
Okay. I think the research is going to be more, we're concentrating more on research that is going to inform practice. And by that I mean, for example, if, for example, we've got a higher incidence of certain types of cancer in a certain area, we want to know what is causing this, what could be the risk factors. That gives us a way in which we can be able to manage the causes.
So
Alright?
we do more of quantitative research as well.
And qualitative as well. So it is both. It is both. But it all depends on what our specific needs are at particular points and for different types of cancer.
Dr. Now I'm coming to you.
Yes. To add on to that,
Yes.
we also have institutes that are doing phase 3 research.
We do.
Phase
Yes,
what?
phase
Three.
3.
Phase three.
Phase 3. So I think we have Aga Khan and KNH that we had several research that
Where
was
is the research
ongoing.
being conducted?
We have several on breast.
Okay.
Yes.
That's okay. So
Yes.
it's breast cancer research.
Yes.
The location, the geographical location where the research is being conducted.
No, we have several in KNH, Eldoret, Aga Khan, and these are research programs that you can take your patient from anywhere in the country and enroll that patient so long as they have the inclusion criteria to participate in that phase 3 trial.
Okay. The reason why I asked the question was going to lead the question I was going to ask you.
Yes.
Different regions in this country
Yes.
are perhaps home to different types of cancers.
Yes.
Correct.
Okay. So this distribution,
Yes.
given the cancers that we see as being prevalent in the country,
Yes.
Can you just give us an indication of what one tends to find in abundance in which part of the country?
Okay, so to start with, the five most common cancers we have in Kenya is breast, cervix, prostate. I think breast, yes, is number one at 16%, cervix at 13%, prostate 8.1%. Then we have esophagus and colorectal.
Yes.
Esophagus is the incidence is increasing quite high.
Why?
Yes, and that's what Dr. was saying. By the way, esophagus is highly prevalent in the northeastern community, and they're trying to do trials and research to see like what drives it, what makes this community of patients have this high risk of esophageal cancer. And negative thing about that is most of the patients come to us as clinicians when they already have grade 4 dysphagia, 3 to 4. Meaning that a patient has been having these symptoms of difficulty in swallowing because there's a mass that's obstructing the pathway of food pass down.
Right.
Yes. And when the patient comes in, initially they just feel like, no, maybe it's some type of tonsillitis or some type of ulcers. They've been taking outpatient medications for
Over
so
the
long.
counter,
Yes,
yeah.
over the counter for so long. And once they come in, that dysphagia is so bad, the patient already has loss of weight and already maybe cannot even take anything solid oral. So with esophageal cancers, the prevalence, as I said, mostly is in the northeastern community, and we're also seeing some high incidence along the Rift Valley.
I sat here with an aspirant. I think he wants to be MP in the northern region, some place in Mandera. And one thing that he pointed out is that they now currently have facilities, health facilities, and lots of doctors that they didn't have before devolution. So considering that now we have, and I think he mentioned that they have like 70 doctors, specifically doctors, not even nurses or clinic officers or whatever. Say doctors, we have 70 of them in this same northeastern region that we're experiencing some of this esophageal cancer she's talking about. So do we have enough personnel? I know we don't have enough personnel, but we have sufficient personnel in those regions to be able, who are able rather, to diagnose some of these diseases.
Like I said earlier, the aspect of personnel is going to be a challenge. And if we are going to wait, for example, to say that oncologists are going to manage our cancer patients,
Right.
it's not going to happen.
All right.
The cancer patients are going to be seen by whichever personnel, the highest level of personnel they have within that region.
Okay.
What we need to look for is a way to support them so the decision making and the clinical decisions are supported by higher level personnel. And that's why I was talking about the disparity in distribution with oncologists and looking for a way of being able to make them still be effective regardless of location.
Okay.
And also, I think it's very important to have high index of suspicion because most of these people usually have been managed for either gastritis, ulcers for very long. Some have been managed like for hemorrhoids for long, and for cervix. By the way, cervix is the number one leading mortality in Kenya. And it's to say like we have widespread screening programs for cervix and it's a treatable disease, and yet still we have a high number of mortalities. We need to do better.
Okay.
Yeah.
I want to go back to that issue of
Telemedicine.
Yeah, I really need to. I need because I'm looking at it as a solution. Sitiocha kunicheka.
No, it is a solution.
Yeah, I'm looking at it as a solution. What kind of infrastructure are we looking at here to be able to ensure that?
I'll give you an
This is
example.
possible, yes.
Since I used my village in Ugenya,
Yeah.
I've got a person sitting in the medical center, a dispensary or health center in a remote location. They get somebody who comes with symptoms that are looking suspicious, possibly of cancer. That is why the aspect I talked about empowering and training healthcare workers to have the high index of suspicion she's talking about, but also just to be skilled enough to be able to identify possible patients with possible cancer. Then now they say there are various things we possibly need to do, various tests and so on. They might need advice from somebody like an oncologist to be able to say, I've got this patient with this ABC, what do I do? What tests do I need to do? And so on. They can connect.
Yeah.
All right? Whether it's via Zoom or whatever mechanism. But they have to have that infrastructure, the internet facility, they've got a computer, and of course people who are trained and on both sides. You synchronize, you have a discussion. They're sitting with the patient. She might say, examine this and this and tell me what part of the body is it? Is there this? Is there swelling in this place and so on? Is the liver enlarged and so on? They say, she says yes. Says, okay, in this patient you need to do these tests. Now, after that, the tests themselves have to be available.
Yes.
All right. So they go and do these tests. After a while, maybe they conference again, and they say these are the results.
All right.
We've done this ABC. So you see how we're progressing cancer care and the diagnosis. Because part of the problem we have is patients go and seek care. They don't get diagnosed. They are being managed for something else. They are told you have got some infection in your alimentary system or gastrointestinal system that is causing blood in your stool.
Yeah.
But it's cancer, all right? They have given drugs told to come back after 2 weeks. They come back, this blood is still there. If anything, it is worse. You remember, you see all these delays.
Yes.
So that's why I'm saying then that is how we come to the point of late diagnosis. By the time they get to a place where it is caught, now the disease has become more advanced. So we've lost time.
Yeah.
That's why I was saying that facility needs to exist. But we must have people who are sufficiently trained in the periphery to be able to catch these conditions and to be able to liaise with people who, so they're speaking the same language. And then we must have the infrastructure, the testing, whether it is imaging, whether it is lab tests and so on, that can be able to support that diagnosis. Then it comes to a point where we have confirmed, for example, this patient has cancer.
Yeah.
Now it becomes easier for us to refer this patient. The referral infrastructure and the funding must be in place as well for the patients to come to a higher level facility and get more advanced care.
So from what I'm hearing and listening to you talk, it seems like that is very possible today if we wanted to do it today.
Yes.
But I also have the feeling that it's not happening.
No.
Yeah?
It's happening.
Is it happening?
It's not just happening as much as one would want it to, but it's happening.
Okay.
Yes.
Yeah, because I thought that maybe we were waiting for something special, a signature somewhere for it to happen.
No.
That's the vibe I had gotten earlier.
But you understand, that's one of the things that I'm talking about, the aspect about collaboration. Because you see, again, one thing we have to understand, we have got different institutions. There has to be collaboration between these institutions. For example, it might be that in my health center it's a public facility.
Yes.
For example, now she's in HCG, it's a private facility. You understand how this aspect of coordination and collaboration needs to come in, and then the aspect of funding needs to come in, because there's no need talking about things we should not get paid for.
Okay.
All right. So all these things need to be coordinated, and that's why I'm saying we have got the resources. We need to optimize their use so that we're getting best value. But I want to demystify this issue of saying that all patients in Kenya will be seen by an oncologist. If we wait for that, we're going to lose all our patients.
Now I understand why when my mother used to go to Nairobi hospital, it used to take at least 2 hours before we saw the doctor, because now I understand very few of them, very many of us as patients.
But you know, there's in areas where HIV was prevalent, there was what called a Kaposi's sarcoma.
Yes.
My friend, the prevalence was high. One doesn't talk about it much now, but it was a problem.
Yeah.
Because when you have patients whose immune systems have been compromised, there's no telling what it is that person is going to exhibit or what it is that is going to land on them. But the knowledge that we are speaking of and how it is that it helps us put into practice the preventative aspects of healthcare, it ties around how we train what we refer to as community health workers, whatever term you want to give them, because these are people who actually live with the wananchi. They live among people.
Yeah.
And the knowledge that is imparted in order to make possible the preventative aspect of healthcare is something that they can easily understand and they can easily put into practice.
Yeah.
So that with what they have, they can then keep escalating it. You see, if you're talking about trying to understand a disease, because before you talk about even preventing it, you really do need to understand it. You need to know what it looks like. You need to know what exhibits. That process of simply understanding at a community level, remember, you also need somebody who these people trust. Because information is just information, but information from somebody you have faith in, you will tend to internalize it quicker.
Yeah.
And a lot of the problems that we have has to do with that. Because cancer, unfortunately, this is why I tie it in, since it reminds me of HIV care and treatment in the early days, because when somebody mentioned HIV and they had AIDS, you're talking death. Cancer, when you mention cancer, somebody already imagines BAS. This is it.
Quisha.
True.
And that is not the truth.
Yeah.
Just to add on to what CT has mentioned there about the community health promoters, that is part of the infrastructure I'm talking about, because that is now human resource infrastructure. We have got 100,000 community health promoters on the ground.
In the entire country?
Yes.
And I understand these individuals are usually volunteers, right?
Yes.
Yeah. So are they well equipped? Are they, because I know they don't necessarily receive a salary, yeah, but they get something at the end of
They
the
get a
day.
stipend,
Okay.
which I think it's about, at the moment, is about 10,000 a month, if I'm not wrong.
Okay.
And it's paid 50-50 by national government and the county governments.
All right.
But that is an army of people we can utilize. The reason why it becomes important is, first of all, they are drawn from the community. They are already trusted. They know the people. Each person is allocated 100 households. Can you imagine if those people went around and started telling them, oh, especially with these big 5 cancers that you talked about, if we could handle these big 5 cancers and reduce their impact, this is half of the cancers we have in the country, is these 5. And yet cancer is a condition you can imagine with over 100
We're talking about
different
brain
types.
tumors, skin cancers.
But there are 5 alone that makes up almost 50% of the cancers in the country. If they go around and tell the ladies, have you been screened, and so on, and the lady initially might be resistant, or it's not necessary, you say, I remember seeing Mama Daddy the other day, she had this and so on, and she went and they got it early. You understand how reinforcing that information. But they have to be equipped. They see somebody who has got some weight loss, which is not explained. They say, mimi appetite sio mzuri, I'm losing weight, niko na joto. Then somebody says, you know what, there's something that's not right here. You go to the local facility. You understand how this is extremely important. So all the resources that we need, we actually already have.
Actually,
we actually already have. We just need to deploy them more.
You have to ask, this agenda when it comes to diseases in the country, we're talking of cancer. The process of ensuring that we control it, contain it, treat it, who's driving this agenda? Because if the conversation is focused on treatment, we've lost the fight.
True.
We've actually lost it. Because before a disease gets to a point where it's killing you, it started somewhere. And that's where the preventative aspect is important.
Yeah.
And believe me, if the focus is preventative, you'd be amazed at how the cases that we keep dealing with for treatment will reduce.
HCG is a private facility, obviously, and we understand that cancer treatment is quite a costly affair. Maybe we can look at those aspects when it comes to your facility and how they're handling these particular cases of cancer. So, for example, right now, would you be able to know how many patients you're currently handling in your facility?
So currently on the radiotherapy machine, we are treating more than 100 patients per day.
100 per day? 100
per day.
These are individuals who come for radiotherapy?
Yes, for radiotherapy.
Okay.
And I think also KU is treating the same number per day. And we're talking about numbers on the machine. The waiting time in a government facility is high, meaning that we really need to increase the radiotherapy treatment machine, because I feel like more timing and has been given to the medical aspect of oncology. We've improved. In the past, we only had radiation treatment available in Nairobi. As I said in the beginning, currently we have radiotherapy machines in Mombasa, Garissa, Nakuru, Eldoret. But still, we need to do better, because radiation is one of the vital treatment modalities for cancer care. So also, like I was speaking to a very senior oncologist, and he told me, like, do you know that one machine should treat about 40 cases per day? But we cannot afford to treat 40 cases a day.
You're doing 100?
100 per day.
So is that putting a strain on the machine, Ama? It's okay?
It is in a bit. It is putting a strain.
I'd like to find out, Kweni, how much is this machine? Because I'm thinking,
do you know the price of the machine?
We see politicians. It's quite costly. We see politicians handing out millions every Sunday in churches and harambes.
It's a few hundred million.
Yeah, I think it's about 500 million.
What? Just one machine?
Just one machine.
So
if I'm not, I don't know the exact figure.
It's $500 million.
So it's $500 million. All right. So it's $500 million.
Yes.
So you want to tell me that, like, in this year alone, we have seen politicians giving out proper money out there.
You've heard politicians saying they're giving money.
So they've not actually. City always has conspiracy theories. Yeah?
No, I'm simply saying you've heard them pledging and saying they're going to give.
So if they pledge, because I'm thinking, if we just take 5 or let's even say 10 of the top politicians in this country, we can have maybe another 2 to 3 machines being added to the let me call it national grid.
You know, one of the things that we have to do, and that's one of the things that lands squarely at our doorstep as NCI, we have to elevate this conversation. Make this a priority. And I like the advocacy groups like the Kenya National Cancer Cancer organizations. They've got a consortium. We call it Kelele Takatifu. I used to call it a joyful noise, but now I had the phrase kelele takatifu, which I like even better. They just need to make noise, because this has to be made a priority. Across across the entire sector. Because like you're saying, we've got a lot of resources we are putting to purposes which don't necessarily serve
they don't
a very useful purpose. These handouts that are given out and so on, sometimes they're very short term in terms of
you
benefit.
can't treat this thing with hiccup donations like those. You actually need policy.
Yes.
However, I'm just saying we can get there, because they're the same guys who make policy.
Actually, it's not a question of getting there.
We can pray under a church. We don't need one costing 350 million. We tunaweza enda hata kwa nyumba yangu naweza omba. Sawa. So what I'm suggesting is we can make that policy, but we clearly know the money is available. We know for a fact.
Unajua, I'm starting the statement with the Kiswahili word unajua. We are talking about healthcare in the country, and we're talking about priorities.
Right.
And we are talking about a disease that is now a problem.
Yes, it is.
You hear more of it, and most of what you hear is surrounded by an absence of actual knowledge as to what should be done. And we're saying we have the building blocks to make it understood, so that the managing of it is that much easier. You already have the personnel. We haven't deployed them fully. See, one of the advantage of age is that you can draw on past experiences. The idea of field workers or extension workers or community workers has been with us for the longest time. And the reason why it is there, because it has worked. Even as groups who you use for collecting specific data for specific regions, they are ideal. But why I talk about policy is not just the broad policy, but the understanding that what we understand and find must be implemented. Now, that priority and the will to ensure that it is done. HIV was tackled because the funding did not come from the government of Kenya.
Okay.
It did not. We got funding from elsewhere, and it was a lot of it. If you look at the funding that Dr. Luenyi is talking about, friends outside the country support it tremendously. We have a policy in this country where a certain portion of our GDP is allocated towards research. We have that policy. How much of that money is used in research, one doesn't really know. So his task is to go beyond the boundaries of what is available locally if he hopes to get this thing done. You have to partner with people who have been doing this for a long time and have an idea of how it is you tackle this thing from the ground going up.
Okay.
Just to comment about funding. Yesterday when we were at the summit, Dr. Gideonji Gitai, the CEO of AMREF, mentioned, and he's also my predecessor as actually chair of NCI. He mentioned that the funding, the reason why especially funding for things like cancer is not as robust, is not as coming as easily from the developed world as for other things, is because a lot of the funding that they give, you must remember they give it to us to protect them from things that we could get and spread to them.
Yes.
So it's about global health security.
Yes.
So it's more about infectious disease. When it's Ebola, they will flood the money there and make sure this Ebola,
because they don't want Ebola in their countries.
HIV was the same. All right? Those kind of things. Now cancer, that risk doesn't really exist of spreading cancer to the US, to develop, you understand, non-communicable. And therefore, that when you guys handle yourselves.
You know,
right?
The reason
and especially in the current scenario where we've got the change in the mindset of leadership of the country that leads the world in the US, it's going to be tough. We have to look for ways of being able to increase the funding that we have ourselves locally, and again optimize those resources to make sure we're using them to the best.
You know, if you just look at two of the most recent cases that were brought up by the Auditor General just recently in the last couple of days, the 44 billion missing from eCitizen, then there's the other 784 missing from Marsabit. If we just take the 44 billion alone, I'm looking at over 80 of these machines. I'm looking at Marsabit having a machine of their own. But anyway, those are cases still in court, so they will deal with them when they deal with them. But here's the now the issue, it's and I'm saying this because I'm sure, I don't know, but I hope that you sit in a committee somewhere with people like the CS of Health and the CS of Treasury when they're making these budgets, to ensure that they understand, because I feel like they know, it's just that they don't understand the situation on the ground, that we actually need these facilities, we need these people, the CHPs, and we need the medical personnel, the oncologists that she was talking about. Do you see it in those places?
I sit in those places occasionally.
Yeah.
And one of the things that I also have to highlight here, before I answer your question, our healthcare system, the architecture has become very complex, and especially with devolution. And I'll tell you why. When you go to see your Council of Governors office, you always see one country, 48 governments. That's literally what we have. We've got a national government taking care of a certain part of the healthcare system, and a very small component, by the way, because they only take care of the national referral hospitals and so on, which are like 6. Then after that, we have got all the other health facilities that are being run by 48 different
governments.
Yes, governments. 47 different governments.
So,
and then what happens is, even those governments, the priorities within those governments there's a huge disparity. You find that there's some counties where the healthcare system is pretty advanced and there's a lot of focus and they prioritize healthcare, and there are others where really you can see it's not a priority, right? So that's why, again, you've got disparity amongst these different places. To complicate things further, the population is not restricted to county. The population is mobile. If their county doesn't have this health facility in Kiambu, they'll come to Nairobi. The ones, for example, when we got the cancer centers, like in Nakuru, for example, one of the challenges they had is they've got the facility in Nakuru, and you've got patients from all the other surrounding counties coming to access the care. And they're like, why should we be the one taking the burden of maintaining this cancer care center?
Yes.
And these other people are not deploying resources. So that complexity. Then, to make matters worse, an additional layer in terms of ownership, you also have private health facilities, you have faith-based facilities. So understand how this aspect about coordination, and yet the patients are one, and the patients can move from one facility anytime at one time or another.
Yeah.
So you have a patient who can come from a private facility like HCG. There are times when the resources become scarce.
Yeah.
They say, now that we go to a public facility, they move, but we want patients to move seamlessly because the care must still be coordinated. And this is where we also lose time. Because as someone tries to get a referral now from a different type facility to another, from a lower one to a higher one, there's time lost, there's money required, there's some authorization required from the person who's paying. So there's a lot of delays in the system, and this hurts.
What we like calling bureaucracy here.
Yes, and that hurts cancer patients a lot.
When people sit in a committee and the healthcare providers are involved and they talk about like the issues on the ground, Dr. was telling me it's one thing to hear and another thing to listen and implement what is being said.
Yeah. So do you actually, you didn't answer that part. Do you sit with these guys? And do they listen?
He said he
said
sits
yes.
with them.
Yeah.
I sit,
Do they listen?
and especially, for example, I'll give you an example.
Yeah.
For example, when it comes to the machines that we're talking about, the radiotherapy machines, we have got some which are already, we had discussions with the CS of Health and the International Atomic Energy Agency. There are already another 2 that are supposed to become, hopefully, to be donated by IEA, and so they beef up this aspect about
And they already donated 2.
Yes, they already
one
did.
In Mombasa. Now Mombasa has 2 radiotherapy machines and one in Nakuru. So these 2 are also donated by IEA.
Yes.
Okay.
So we've got an additional one. So there are things that are being done. I'm just saying there's still a lot of work that needs to be done.
Okay.
There's some things that are in progress. If you were to ask me my honest position, do they listen enough? And especially, you see, that's what I'm saying, even government is very complex.
Yeah.
It's not even something that's purely the mandate of the CS of Health, for example. The CS of Health has to work. The people through the PSs, they have got to get the various, they go and sit together with everybody else and put in their requests in the form of these budget requests and so on. And then you hear this term, fiscal space is always tight, and they'll allocate the priorities. So the truth is, you never really get what you ask for.
Yeah.
But my approach has always been get what you can and then work with it, make as much impact as you can as you keep asking for more.
You know what is of interest when you talk about cancer and the understanding of it? As you're speaking, I was thinking to myself, if certain types of cancers are prevalent in certain parts of the country, just the process of understanding why it is that those cancers are prevalent there, and it will be associated with maybe the environment, if I'm being broad-minded.
Yes.
Epigenetics.
Yes, exactly. Certain cultural practices that people have, certain dietary considerations that people have, all these things. Now, that understanding is something we don't have to get from anybody's country. It's something that we can do here.
Yes.
It's something that we can actually easily understand. Now, how do we move from looking at this thing as something that is a problem and a burden to looking at this same issue as something that we can actually overcome and we can actually sort out? Because if I approach an issue with the mindset of this thing is difficult, then I start with a load on my head.
You've already been defeated.
I'm already encumbered. But if I start with the idea that this is something that we can do, I'll be looking at the same thing, but I'll be looking at it differently. My question now, when we look at cancer, is it that now we are able to detect cancer more readily and more easily? Or is it that the prevalence is actually real and that cancer is actually a growth industry in the country and that the prevalence of this cancer is actually increasing? Or is it that because we are many, what exactly are we dealing with?
It is all of them.
All of them.
It is all of them. Because we are first of all what we refer to as modifiable risk factors. Our environment has got challenges. And you mentioned, for example, things to do with the environment. These areas become very testy sometimes, and that's why multi-sectoral collaboration is required. When you go to the agricultural sector, we've got some certain carcinogens there in terms of chemicals,
Pesticides.
whether it's
Yes.
pesticides, fertilizers. That's a real issue. These things are making their way. For example, you've got waste that's coming from different factories. These are the things that contribute. It ends up in drinking water and so on. Those are the kind of challenges. So environment, that's why it's multi-sectoral. This is a whole of government approach. Even during our conference, what happened is you have to invite people from the different sectors and the PSs, the leadership from the different ministries, because you can't do this alone. You need education. When you want to say you want to vaccinate girls against HPV, Ministry of Education has to be involved. When you want to talk about environment, the agriculture, for example, has to be involved. So there are very many other ministries that are required. But to answer CT's question, our environment is contributing. That has changed. It is very different from what we had maybe 30, 50 years ago when people were just doing regular agriculture, growing without fertilizer, organically. Yes. Then you've got the lifestyle. People have got lifestyle factors. Our diets have changed. This obesity is a bigger problem. All these things are increasing the incidence of cancer. We are taking more sugar in our foods. We are consuming more alcohol, excessive consumption. Tobacco is a challenge. Those are things that are increasing incidence of cancer. Then in addition to that, we are also more, and we are also diagnosing more of them and diagnosing. We've got the tools now to be able to tell that it's not just some strange disease that has killed so and so that somebody has. Now we can actually go down and actually find and say it is this form of cancer, which before wasn't possible.
You know, I want to go back to something very basic. What exactly is cancer? This thing, what is it that makes it what it is, and what is it that makes it as dangerous as it is, and what is it that it does to us?
The oncologist in the house.
What is it?
So cancer is an abnormal growth of cells. So this cell, when it gets an impact, it undergoes DNA damage.
These are cells in our
Yes,
body.
cells in our body.
Okay.
The human body is made up of millions of cells. Now, when this cell gets a damage, impact, either from many factors, and these factors are usually multiple, like Dr. has said, from environmental to epigenetics, genetics, and all that. So when we have DNA damage, the cell is supposed to either undergo repair or undergo cell death. So when these two does not happen, the cell undergoes mutation and we have an abnormal cell growth.
Dr. Pause. You know, when you say repair, my mind immediately went into vehicle repair.
Panel beating.
And I was thinking, okay. So at what point do we panel beat this cancer cell?
CT.
And this repair, is it something the body manages on its own?
Yes, the body has
What do you need to
own-
give your body so that it manages such
the body
things
has
better?
its own mechanism of repair. So either when repair doesn't happen or cell death doesn't happen, then this cell continues to grow abnormally. Now, there was...
Abnormal here means what exactly? If
So
it was,
if the DNA is damaged and this cell doesn't die, that means this cell has literally changed its identity. So it grows as something different. So it multiplies because cells multiply. So it might multiplies to the next cell and the next cell, and eventually when they become millions, it's cancer.
Don't go there. So essentially, let's say this cell is a Kenyan.
Yes.
So why are you laughing, Doctor?
Who has gone rogue?
Let's use this analogy.
He stops being a Kenyan. What does he become, a Tanzanian?
So if we're going to use countries, nationalities, so if it stops being a Kenyan,
Yes.
it ends up being a rogue Kenyan. So it's still a Kenyan.
Yes.
It's just a rogue Kenyan. And then now it goes, multiplying and taking up resources from the
Then
other
it isn't
cells.
a Kenyan or a Tanzanian, it's an East African now. So it's now...
Yeah.
Let me try and simplify this so that we don't lose the wananchi. Because I think it's an important point.
Right.
We have got cells in the body. They normally are specific for particular types. They perform a particular function and so on. Then now you've got some cells which become abnormal, regardless of the reason, like the DNA and so on, but that's too complicated.
Yeah.
The cells just become abnormal. They are not behaving the way they should. They start, first of all, they grow uncontrollably. Normally, cells will grow, and based on body's need, and they grow. The number is fairly constant. So, for example, you've got X number of cells as a constant. Some are always being formed, some are dying. So, then you've got some cells that just run amok. They start growing uncontrollably. They start now, first of all, not respecting boundaries. They are now stretching into territories which are not theirs. So, it's invading other tissues around it. Sometimes even go in the bloodstream, or what we call part of the circulatory system, lymphatic system, and spread and go to other places and start growing there again uncontrollably. All right? So that is what cancer cells are. So sometimes, most of the time, they form a mass or a tumor or a swelling. All right? But then sometimes they also spread, and wherever they go, they are causing havoc.
So
That's what cancer is.
Again, they form a cartel.
Yeah. They form a cartel.
Yes.
Yes, and I just like for 1 centimeter of cell, like a growth, for you to identify that this is a growth, usually it has 1 centimeter mass has 1 times 10 to the power 6 cancer cells.
So that's a million.
Yes, in a 1 centimeter mass of abnormal cancer cells.
Yeah.
And I also want to add on that there is hallmark of cancer cells. What does this mean? It's like the characteristics of these cells that make them to grow and spread. Like they're able to evade the immune system. Your immune system is supposed to protect you from different
rogue
things.
elements. Yeah.
Yes, but the cancer cells form a mechanism in which they're able to invade, metastasize, evade the immune system, and like they have their own supply. They are not dependent on the blood supply or anything from the surrounding system. They form their own supply of everything.
So that means that they create their own network of
Yes.
blood capillaries,
Yes.
vessels, and all
Yes,
that.
yes,
The
yes.
cartel.
Yeah. Actually,
And they are quite
So
resistant.
they are
It's
a
a cartel.
criminal enterprise.
Yes.
So now that we've understood, and hopefully the listener has also understood what cancer is. So when we do chemotherapy,
Yes.
So what are we doing? We are attacking this particular cell. In how do we know that this chemotherapy will attack the skin cancer or the leukemia or the colon cancer?
So what chemo does is there are different mechanism of actions of the different chemos available. So it goes and kills the cancer cell. But with the current treatment modalities, we are moving more towards targeted treatment.
Okay.
You see, with chemo, there is the damage to the cancer cells, but there is also like there may be some side effects of the chemotherapy that may be due to damage of the normal cells.
All right.
Now, like for GI, the patient may be getting nausea, vomiting, some diarrhea, because the epithelial cells of the GI lining usually undergo acute damage.
Okay.
And then they repair themselves because they're normal cells. They undergo repair. It's unlike the cancer cells. So what chemotherapy does, it makes that attacks the cancer cell. But with the current modality, with different types of cancers, we are moving towards targeted treatment. That is why genomics is very important. In the research that we are talking about, we have to identify what is driving this cancer to grow.
All right.
Which mutation is causing this cancer to grow.
What we don't have an understanding is why, despite all these treatment options and opportunities we have in Kenya, we still have a lot of people going out of the country. And it's understandable. There are some people who think that perhaps out there we have better qualified doctors or better facilities and so on and so forth. So, Dr. Lenny, this one is yours. Is it true that we have better treatment out there, outside Kenya, than we have here in Kenya?
Sometimes we do have better treatment out there.
Okay.
That is a fact. It all depends on where you go and for what condition. There are certain conditions we don't have significant experience or expertise, or we might not have the tools to be able to manage.
Such as?
All right. And I'll say more higher level things. I'll let the oncologist say. I don't want to have.
I wanted to ask the same question, such as because
Dr. Lenny is protecting his career.
Let me tell you one thing.
Yes,
Medicine
yes.
is both a science and an art. And I'll give you an example. If you have a patient who needs a certain type of surgery, for example, all right, will you go to the surgeon who has done 2 cases or the one who has done 1,000?
All right.
All right. That's why I'm saying it's
fair
not
question.
about being able to perform the procedure. So sometimes we've got people out there who have got higher levels of experience. I'll give the example of India because it's a common one. India has got a population of 1.5 billion people. The levels of experience and specialization, just by virtue of the numbers they have, you can have somebody focus on a very specific condition and be able to manage massive numbers of that condition, as opposed to us. All right. So there are times that you've got better expertise out there. That having been said, our local capacity is extremely high. And over the years, we've got a lot of people who are trained, including my colleague here, who is trained in those places out of the country that some people want to go for treatment. We have got the expertise locally. So what we need is to have a system that supports patients to get treatment locally. One of the things that we fail as a medical fraternity is that based on our background and our training, we are not people who solicit for work. We don't market ourselves. We don't, and that also includes
Are you allowed to?
Technically, we are. In terms of being able to tell people what services we offer, we should. We should. All right.
So the problem, nothing prohibits you.
The problem is there's a fine line that you cannot cross. You can't start going and saying I'm the best. This come for the best. You know those kind of things. Advertising. I know those are the things that we shy away from because you can see how it can get unethical. All right.
Yeah.
And especially when it has no solid basis. A lot of the people who shout the loudest might not be the people who are actually the best. All right.
But you see, you have competition because if you look at the papers, you'll find that there's a professor, God knows what and what and what, who cures everything.
Yes.
Okay?
Yes.
If you have a love problem, he can sort it out for you.
Yes.
Nguvu za kiume.
Yes. If
He does everything.
if you don't have a job, he can organize it for you.
And he cures cancer, most importantly.
Most importantly, he cures cancer.
Whereas for us, a lot of the time we're telling we can only manage it, cure is not possible.
Yes.
But going back to my point, we have got to be better at telling people what services are available locally.
Yeah.
What treatments they can get and to what extent. Because a lot of the people who leave this country, by the way, just don't have the information that these services are available locally.
Doctor, if I may just opine on something. When you talk about medical tourism, most Kenyans don't understand that there are very many people within the region who come to Kenya
for the same thing.
Yes, they actually come here, and we have not a few, many people. Some from places where you would think they wouldn't leave their country to come here, and yet they do.
Are you talking about Tanzania?
No, not Tanzania.
No.
I currently have patients from DRC, South Sudan, Northern Africa.
Yeah.
Yes, several.
Even South Africans come here for treatment, just so that you understand. And we also go there for treatment.
Yeah. Actually, doctor,
there are even people who come from developed countries because they cannot be able to either afford the treatments there or they have got a too long a wait.
Yeah.
They come and be able to get the procedure high level here. So it's in terms of marketing, what we do, we have to get that information out. The second thing is the cost of this care. And the cost of this care is one of these things that we need to have a wider cost of care debate amongst our system, because one of the things that's driving people out of this country again is the cost. As a medical fraternity, whether it's healthcare providers, institutional or individual, we have to discuss this issue, because a lot of economies, the jurisdictions out there, for example India, make their money from the volumes. All right?
Yes.
Some people think about it from a very myopic perspective of saying, I do only 2 cases a year, so I better make enough money out of these 2. And by virtue of pricing it wrong, by virtue of pricing it wrong, you're going to send away everybody. So what we end up being is a clearing and forwarding agency, where you diagnose people, next thing you know, they have left. But there's a lot of problems with this medical tourism. In fact, I don't like that term. I prefer the term cross-border contracting of medical services, because tourism, I just see somebody on a beach somewhere, and that's not what they're going to. We're going out there to do when you say medical tourism. But there's a lot of issues. What we need to address is underlying reasons as to why people are going. Once we understand that, then we fix it. But in the absence of us getting to the point where we understand that, trying to block people, for example, saying we're not going to provide public funding for you to go out of the country, we can't deny those people who actually need to go out of the country. But for everybody, especially when it's publicly funded, for everybody whose medical condition can be managed effectively locally, they must.
Dr. Zahra, I feel like you have something to say.
I feel like as a country, we are able to manage almost, if not all, of what is provided outside. Very honestly speaking, yes, the specialist numbers is not that high, but we have very highly specialized individuals who can provide excellent care to patients. This comes from a perspective where I have sat and seen patients coming from outside the country whose management does not align with the current recommendations. People will go, like, let's say, and I was just giving this example, a patient with breast cancer, locally advanced. Nowadays, we don't treat breast cancer as one. You have to know the biology behind it. You have to do certain tests to know what drives this cancer, so that you can be sure, does this patient need treatment before the surgery, according to the stage. So from the biological drivers, you will know if the patient needs targeted plus chemo before surgery, because if this tumor shrinks, now from an oncology perspective, if this tumor shrinks before surgery and this patient gets something called a pathological complete response, meaning that after surgery, you check where the tumor was microscopically and there's no cancer cell, these patients have the best outcome. Understood?
Right.
But this treatment, the neoadjuvant, which means treatment that is given prior to surgery, usually takes about 5 to 6 months. You can't tell me that all patients going outside are able to stay there for 6 months. Not all can do that, because it's more expensive. So when patients go out and they're given surgery as this first option for some of the locally advanced disease, that is not the best practice. You understand?
Yes.
While this patient could have gotten better management back at home, but maybe we have to build trust. Patients have to trust us for them to understand that we are able to do most, if not everything, that is provided in all these in all these countries.
Dr. Zahra, the practice that we observe from you practitioners of healthcare is that you're accustomed to people coming to you. You don't go to them.
But that's the whole point of programs where we do screening. And I think we have certain bodies that screening programs are widely spread, but there are some rural areas where there was less than 1% uptake.
What I'm saying is not a criticism of the practice. No. I am simply saying that a window opportunity exists which you haven't taken. If what we're doing here was done more often, and you in this sphere of influence spoke more about what you did, more people would understand. See, this is radio, and radio is good because of its terrestrial nature. I am simply saying that medical practitioners do themselves a disservice by not telling people the things that we are now talking about to the extent that we need to talk about them, because doctors are trusted.
I think this is a good start, and I do agree with you. We should do more of this so that patients can be able to understand what is available, what we are able to offer, and like the right modalities of treatment. It's not just about being treated, but being treated properly.
You see, like we're talking of cancers, and we know that there are parts of the country where certain things are prevalent, as we've said. Now, when this is spoken of, and you take the time to go to the thing about our media, it's very broad-based. No pun intended here. No pun intended. We are able to communicate these things even in those regions where we find these cancers prevalent. and go into even details, talk about the signs and symptoms that one sees. Again, I'm going back to what I started off with.
Yes, preventive.
The opportunity to do justice to your chosen professions exists. The advantage is not being taken. That's really my point.
Yes.
Yeah.
And just to agree with that as well, I think we need to restore the confidence in our healthcare system.
Sure.
Entire healthcare system, whether it's individual practitioners, whether it's institutions and so on. And I'll give you an example. You have an institution somewhere, one incident occurs, however bad it is, and in fact, it can be as bad as, like we talked about the other day, where you have a patient who is murdered within a hospital facility,
Yes.
right? And that can happen in any sector. But you see, that gets highlighted to an extent that it does so much damage to the confidence in that system, and yet you've got hundreds of thousands of patients who have got good outcomes, which nobody talks about. You understand how, when it comes to highlighting some of these things, we do ourselves a disservice by not telling people what we're doing. You know, it could be as simple as saying, in this particular facility, we have had 10,000 surgeries. For example, if it was KNH, 10,000 surgeries for this particular condition, the outcomes have been this.
Yes.
And it's that simple information patients can understand.
Yeah.
So if somebody has got some form of cancer and needs that surgery, he says, no, already 10,000 have been done and 9,700 and something had got good outcomes.
And this is a good
the
place
other
to
one,
go.
this is a good place to go. You understand how just that information alone is important. Secondly, you've got, for example, when you've got healthcare worker unrest, when doctors are on strike for whatever reason, it is highlighted and it's on TV consistently the whole time. It makes it look like the whole healthcare system is paralyzed because of
Tend
this.
to highlight on the
And that's what I'm
negatives.
telling you. That's why we have to do a better job. There's an aspect of patriotism a little bit here, and I keep giving examples, like even in the US when you had 9/11,
Yeah.
they didn't even show anything. Because it becomes patriotism, it becomes a national issue. They're not going to give the terrorists the pleasure of looking at Americans.
Of giving them free advertisements
Yes, that's what I'm
about
saying.
how successful they've been.
So that's what I'm saying. There are certain things about our healthcare system where we could do things to be able to restore this confidence, because that is part of the reason why we're losing our patients and they're going out of the country. The worst part is they're going out of the country a lot of time to institutions that are inferior
True.
to where they can get care here. You know, you can go to a level 2, 3 facility in India and still come back and saying, me, I've gone to India for treatment, and left a level 6 facilities in Kenya, which could have done the job much better and at a lower price. So, in summary, we have to restore confidence in our healthcare system. We have to do a better job of letting people know what services are. If you want to know how rudimentary things are, even for me as a healthcare professional, I get a patient whom I need to refer to a gynecologist in Mombasa.
Yeah.
I don't know which gynecologist is there. Do you know what we do? We go to our WhatsApp group for
Yes.
the class group and say, hey, by the way,
Ni nani ako Mombasa?
the truth is, I actually don't even know that person.
Yeah.
But it's based on a referral and I
Yeah.
sent.
Yeah.
All right? We
All
just
right.
need to have a system where information is more readily available.
And sorry.
Adding
The-
to what Dr. Ari has
Please.
said, what we are able to do. Many people, when you tell them they're stage 4, people think that's the end of life. Yes, but currently, even stage 4, we divide it into oligometastatic disease. So,
Sorry.
meaning
In English.
oligometastatic, meaning, so what does stage 4 mean? Stage 4 means the cancer has spread from where it started to another organ. Understood? So like the cancer started in the breast but has spread to the liver. The cancer started in the colon, but you have liver spread, or you have lung spread to another organ. That is what stage 4 means. Stage 1, 2, 3 is a cancer that is it's localized, locally or loco-regional within the normal regional area, the lymphatic system. So currently, we are able to treat oligometastatic. Oligometastatic means
Break it
you
down.
have
Oligo is
either-
who?
Oligo is a
Zafir.
primary tumor.
Not someone who comes from the terrorist
No.
Not a relative of mine.
Yes.
Limited metastasis, limited spread.
Yes.
And we have a wide definition of oligometastatic. Some people
Right.
say 3 lesions, some up to 5, but it all depends with where it has spread and the remnant reserve. So like for cancer of the colon, for example, that you have spread to the liver. This is stage 4 disease, but it's still we are still able to treat it curatively, either with surgery in both areas after treatment with either chemo and radio, or with stereotactic radiotherapy to the metastatic lesion.
Okay.
Understood?
Yes.
Yes, we are able to offer those services. So even in such scenarios, patients honestly do not need to travel for treatment.
Once in a while, whenever I log onto YouTube and I watch a video too, there's this advert that comes. There's a gentleman, he's Caucasian, so he's on a bed, he's clearly sick from what I see, but he's advertising this particular facility. I think it's a facility in the US, and he goes on to say, I think it's an orthopedic institution. So he goes on to say the way he's received this surgery and it's working very well. So basically he's advertising this place, and he's telling people to do what? To go and get treatment there in case they have a similar situation. I don't see that happening here in Kenya. I think once or twice I have seen an advert by Aga Khan, but I do not see like proper adverts coming from HCG and even the Kenya Cancer Institute, just to tell people that, look, this is what is happening in the country as far as cancer is concerned. These are the available treatments. You can get them here, We have collaborated with HCG or any other institution. So are we bound to see that? We don't even see you guys coming to the ground, whether it's on a day that we're celebrating cancer, or just publicizing cancer. I think October is Cancer Month or something. So I honestly do not feel your presence on the ground, just letting people know that this is what is available, this is what is happening, and this is how you can get treated. I think majority of us get to know that we are sick once symptoms have gotten really severe, like you said earlier on. So where are we on that?
That's a challenge which we have taken, and we've taken very seriously in terms of being able to elevate this conversation. To the level where the public are aware of, first of all, who NCI are, what our roles is. It is very important for us to be able to tell people, for example, even when they have got a cancer diagnosis, which centers they can visit and visit for what. All right? So it is important for us to map out all the facilities, say this is the services that are available here. For example, like she mentioned, we've got places that can do all three big things, for example, chemotherapy, radiotherapy, and what's the other one? Immunotherapy, for example. But also have the surgery. That's what I meant. Surgery and the medical therapies and radiotherapy. You can have it in these places. In this particular place, you can have only these two. Even for public health, private health facilities, these are the places you can go for this and this. We need to even get to the point where we tell people this is the pricing.
Yeah.
And that is one of the things that we can help people in terms of managing resources, because the resources are always limited. They need to be able to know where they can get best bang for their buck and still maintain quality, isn't it? So you might be going to a place, to a particular facility, and you're paying 200,000-300,000 shillings for a particular procedure, whereas you can go and get it somewhere else without compromising quality at 150,000. So these are the things that we need to help. Information just has to be more available. So talking about the cancer days and so on, the approach is they're supposed to be used more to publicize these efforts and so on. It's a good PR event. But in terms of impact, we want it to be that things like screening and so on are just part of everyday regular medical care, as opposed to saying we have it on one particular day, because the impact is not that great.
Let me ask this question. If you look at the health facilities that we have, what level of health facility is able to screen?
Level 1, 2, 3, 4.
We want it at level 2, 3. And that's the primary.
Currently, as we speak, where are we able to screen cancer? What level? Right now?
We can screen cancer at level 2 and level 3. And
we can.
But not every part of the country. Remember how I told you?
Not all level 2s, not all level 3s.
Yes, this architecture is complex. At the moment, even if you go for malaria treatment, there's some malaria treatment facilities that you have in level 2, level 3, that you might not even be able to get that treatment. And the others that are able to do much more. And I'll give examples. For example, I'm hearing very good reports from places like Muranga, for example, where the healthcare delivery, and places like Kisumu, where healthcare delivery is really a priority. And that's why I'm saying these are the things that we need to tell people. And it also introduces competition amongst even the counties, for example. You can imagine what impact it would have if, as National Cancer Institute, we tell people these are the counties where you're able to get.
You see why I asked the question? All these health facilities have boards.
Yes.
And the boards tend to be locals. These are people who are known within the communities, and that's why they are in those boards. Now, if we're talking about a 360 approach to ensuring that information is cascaded to the people who need it most, something like screening, I'm focusing on the